Hi, I'm Jess. I'm Chief Relationship Officer at MedBrief, and welcome to the first episode of the Med Briefing. This is our brand new podcast and we're really excited to bring it to you. We're hoping that the topics will be varied and they will be of interest to legal professionals, medics and other people involved in the medico-legal industry. During our first episode, we're going to hear from the very talented Meg and Jess, who've worked together for a long time in the NHS as midwives, and they're going to explore the topic about when things go wrong in midwifery, how care is escalated, and common signs that you will recognise, I'm sure, from your cases. We will have other episodes coming out later this year. We're going to chat to charities. We're going to talk to other professionals within the industry. So we really hope that you can join us and that you enjoy our podcast.
So in this episode, we're talking about child brain injuries, what they are, how midwives relate to them, and what lawyers should know about them.
So there are a number of child brain injuries that we come across. The most commonly known one is probably hypoxic ischemic encephalopathy, which is more known as HIE, easier to say. That is to do with hypoxia, which is a starvation of oxygen to the brain, and it can occur either antenatally, but it mostly occurs during labour or in the immediate neonatal period.
Yes, and that's the one that generally is graded, and there could be levels in which babies are affected. I think that's what we generally find most in midwifery, and I think when you think about brain injury cases, this is what you're gonna hear, what you're gonna see, and what you're gonna think about.
And unfortunately, most of the HIE cases, they are linked to malpractice, which is of course where our role comes in. And when they're graded, they are usually in hospital at the time and require ongoing follow-up. And most of the time, the outcomes are not truly known at that initial period until further down the line.
We've listed kind of the main culprit, as we could say. But there are many different types, a lot that we would know as midwives, some that we might not know so much. We've got PVL, which is the white matter of the brain, when there's been hypoxia that's been damaged. It's picked up on MRIs, and there's lots of different factors involved within that.
So we also see IVH, which is intraventricular hemorrhage, and that is damage to the fragile blood vessels that are in the brain. Susceptibility is usually with premature infants because of their size and the fact that they're not fully grown when they're born.
So CVST, blood clot on the brain, basically. So it can cause things like strokes. Again, generally with premature babies because their blood vessels are so fragile.
So stroke's not as common, but it's just a blockage of the blood flow in the brain. Can be caused by an underlying clotting disorder, but it can also be just from traumatic birth in general.
Then we have traumatic brain injury, I think most associated with forceps and von twos. It's not always a case of traumatic brain injury, but if there's things like skull fractures, then it's something that we would look into.
And then we also see something called connectus, which is untreated severe jaundice, which is a build-up of the bilirubin in the baby's bloodstream, where parents will often say the baby looks a little bit yellow in the first few days. Normally physiological, but when it's pathological and it's left untreated, it can cause some really severe outcomes.
And just to add, it's incredibly rare. Don't think I've ever seen a case.
So we've already spoken about the different types of neonatal brain injury, but the common outcomes that you might find and that people have probably heard of. So the major one, cerebral palsy. Again, that's graded. It can be mild, moderate, severe, depending on the child. Also epilepsy, so they can even start having strokes, and they can start having seizures from very early on in the neonatal period. Doesn't necessarily mean it's definitively going to be epilepsy, but they can be diagnosed with that further down the line.
You can also see it where often they don't start having the seizures till they're 2. So often the brain injury can develop and then the seizures start. So it can be quite a surprise for parents.
Yeah, so that ties in with the fact that a lot of these birth injuries, it's just a delay in development that the parents start to notice. It's not always recognisable from birth. They maybe have an idea or they have a thought that there might be something developmentally wrong with their child, but until they start maybe not hitting their milestones and then they start to realise that they're different to the other children, they're not picking up that like there's sensory issues or they've got like a impaired vision or they just aren't growing on the centiles as you would expect. So it's a case of weighing it up. It's a short-term management, but it's also long-term, and sometimes parents won't have any clue that anything had actually occurred at birth that might actually have affected their child.
Yeah, and it's crazy how you could potentially line up 10 children with birth injury, even have the same grade, but yet develop so differently. And I think this is why it's important, we do our job correctly and look at all the notes and, what's actually happening to this child. Is there a speech delay? Do they need special shoes? And what support they need? And not one child is the same. And the family, they want answers, but I think it's such a huge waiting game and it must be terrifying for them.
Yeah, and I think as well for families, they go to the professionals because they want answers, but sometimes because it's so multifactorial, they're not able to get those answers, and they can't often say, if that had been done differently at birth, then this would have been our outcome. I think it's also important for us to just make people aware that unfortunately birth injuries, they're not always a result of malpractice and like really poor management in labour. Don't get me wrong, a lot are, and that's really unfortunate. But sometimes it's just an acute event that literally no one could have predicted, no one could have ever thought would happen. So for example, a cord prolapse. If you have a cord prolapse not in a hospital environment, the chances of survival are really poor. That is where the waters go, and then the cord will fall through the cervix, and as a result there is a reduced blood flow to the baby. We can obviously manage that in hospital and try and prevent a really poor outcome, but with transfer times and then getting to theatre for an imminent delivery, we just don't know how long that baby would have. So it's really important that professionals give women all this information at the time if they are at a predisposed risk of these things. So it all depends on the woman's risk factors. I think even if you've got what's deemed a low risk pregnancy, it could happen to anybody and you just can't predict it.
Yeah, very similar to these premature babies, especially micro-premies, if they're born at 24 weeks. I think we often see a lot of cases in this way and you think, gosh, you can understand the parents are so distraught by it, but unfortunately, a premature baby has a huge mountain to climb and it's not always easy. So there's a number of key risks that can happen during labour. I think there's a couple of quite huge ones, the first being fetal monitoring. So different types of fetal monitoring. You've got intermittent auscultation, which is generally, your low-risk women. You're listening in with a little machine every 15 minutes, counting in your head, having a feel of the contraction. Then CTG traces, which we're going to, you see hugely now because not many people are low risk. And then you've got fetal scalp monitoring, which again is very similar to CTG. It all prints out on there. The risks in that, huge. Obviously, they are there for a reason. They are there because there's a worry and there's a concern. The way that people read them differ hugely. And the guidelines change at what feels like every few years, really. And I think as a midwife, keeping on top of that is bananas and really, really difficult. And I think actually when you look back on our cases, I mean, the CTGs are very valuable in kind of pulling the picture together. It's crazy how different people react to them and how different people relate to them in labour.
And I think as well comes down to how confident people are in their own practice. So I've mainly been a core labour ward midwife for my entire career and I still practice now. So I can use Dopplers, I can use CTGs easily, but no baby is the same. And I think it's the whole picture. So you can have the exact same CTG of like the exact same gestation infant with the exact same risk factors, but each baby will cope with labour differently. Some babies don't cope with labour at all and they're already predisposed with risk factors. But if we don't know those risk factors because of perhaps they've not attended appointments or they weren't referred as necessary, then we're not going to know the appropriate ways in which to use the fetal monitoring. I think nowadays we are more on the side of caution with it and practically everybody is given a CTG. Very, very rarely now is a woman deemed low risk enough to have intermittent auscultation. But yeah, you made a really good point. I think it's really difficult when you're in a room with someone. And even though I've worked at multiple trusts and we all use the same system of what's called fresh eyes. So we work obviously really long shifts, you get really tired. If you're in a room with someone all day and you're looking at the same trace of a baby over and over again, you get blind to things that are changing with that picture. And so every hour it is policy that another midwife or a doctor comes into the room and does fresh eyes and agrees with you that what you're seeing is normal and that the management in that room can continue and that there's no nothing life-threatening happening right now that would need delivery or escalation. But you made a really good point that not everyone agrees with you. So, we interpret things differently. And even though the guidelines are there, they are just a guideline. And I think with the experience you gain, some would say that certain things on the CTG were okay and okay to continue for potentially a little bit longer, which leads into the fact that a lot of the cases we see are a delay in recognising when that baby is no longer coping with labour. People don't pick up, even with fresh eyes, that a review was potentially needed and that something was going wrong. And then that's where we see these negative outcomes where babies would have had a better outcome if they'd been delivered sooner. Recognising a failure to progress in labour, I think everyone's a little bit scared to kind of label a lady with failure to progress because they don't like the word. It's, a failure of labour. But it can actually be a really risky game if that baby is physically stuck and labour is completely halted. It puts the baby at such risk. And sometimes I think we do keep going a little bit longer than probably is safe.
Yeah, and I think there's a lot of associated risk with syntocinon at that point. The failure to progress and this wanting the normal birth and, concerning about a lot of women nowadays really do not want cesarean sections and will go far. And then the risk there with syntocinon and how it can create such a hypoxic environment potentially, and how the CTGs connect with that. And I think it's such a huge balancing act to give that lady what she wants, but making sure that the baby is safe and that labour progresses normally as can in such these high risk births.
Yeah, and it's having that confidence, isn't it? I think depends on the team that you're working with, but like I said, it's having confidence in your own practice, recognising when this is going wrong here and I'm actually quite worried now. The more exposure you have to those more challenging situations, the more confident you feel. But that's where all our training comes in. We don't just attend training days with only midwives. We attend them with the multidisciplinary team so that the doctors' names, what they're like to practice with, and what their skill set is. It's having the ability to walk into a room and handle an emergency at the time with the same goal in mind, which is to get a really positive outcome. Nobody goes to work thinking, I would like a negative outcome today. You all go with the same intention, which is a healthy mum and a healthy baby at the end of it. But I think we do really struggle to get that right every single time.
Yeah, and I think especially in really high intense emergencies such as shoulder dystocia and cord prolapses, they are frightening, scary. And you need that group support and, you need the junior midwife to be there to learn about what to do. You need the senior midwife there to run through the timings, to keep an eye on everything. You need the doctors there to perform the correct manoeuvres or to get the baby to theatre really quickly. And it's that fine balance again, isn't it, between we don't see, we do see them very often, but you will have a set group of people. Like me, for example, I worked in labour ward and I've still never seen a cord prolapse and only had a couple of shoulder dystocias. And, in the time your adrenaline is going crazy, actually you've got a job to do.
So when we're doing our job, looking through the records, I think there's like a few things that we'd look for that are kind of like warning signs within the record that potentially this is heading towards birth injury. So when you even look at the antenatal period, what we're initially looking at is how many attendances to hospital have they had? Have they had none? Or have they had multiple with the same issue over and over and over again? And actually guidelines haven't been followed. And for example, they've presented with reduced movements of their baby. They keep saying they're not happy. And they've had missed opportunities to be referred for a scan, which could have maybe determined earlier on that the baby was actually struggling. There was maybe not as much blood flow in the cord, so the baby was struggling to grow, which would have put that baby at an increased risk in labour of not coping so well. And had we have known that, the management may have been different. So most women in pregnancy are given a number to call the maternity unit, and they attend and are ideally meant to be seen within 15 minutes of their initial concern. But with the NHS and just with general pressures and how things are with staffing, there's been a lot of reviews into the fact that women are attending, not being seen within that time for midwives to make a full assessment And so they are potentially left in danger for a longer period of time, which is delaying the treatment to their baby, which could lead, obviously, to a poor outcome.
Yeah, I think we often see it, don't we, where women are started on CTGs and they are left for some time because I think you're so under pressure. Often 2 or 3 women, you start that CTG, you kind of stand there for a minute, see what you think is a normal heart rate, you dive off somewhere else, and actually you forget, or you're tied somewhere else, and actually you've got a really poor CTG that should have been acted upon. And I think that can be really difficult to manage, especially with busy units. And I know there's lots of different triage systems within the NHS that try and combat that, but equally short staffing is always going to be an issue. Even things like checking up on investigations, so your urinalysis and your blood results, how many times do you see where they're forgotten to do? For example, a woman could be picked up with PET early on with the traces of protein and it's not been completed. Or she said, oh, actually, I don't need a wee now, and you forget. Or if they have bloods taken, it's either not chased, and they can be the really early warning signs that actually someone has a condition which may affect them in labour and actually could progress potentially to a brain injury.
And I think as well, you just kind of said about staffing, the one thing that just records will never ever be able to depict is like the sheer volume of your work at the time. You can't depict that in documentation. For us to be able to sit there and read, and we think to ourselves, well, why is there a 20-minute gap in this documentation? Like, based off what I've seen already, I would have expected there to have been something to fill that gap. But unless a clinician has the time, which ironically they usually don't, to sit and write, I have X amount of patients, consultant is in theatre with this episode of care, I've bleeped and I've had no response, and that's where your failure to escalate, it looks like a failure to escalate, but what it doesn't show is how busy you truly were. And I've read so many records where there's just such a huge gap, and then all of a sudden there's a poor outcome, but there was a bit of care there, but just nobody was actually available to actually document in that moment. So that's it's a huge issue when I'm looking at records, because you would expect there to be something in that gap. And then parents lead themselves down a path of thinking, well, why was I not important during that 20-minute period, for example? But actually, it was just that the workload pressures were just so high that you're trying to juggle 1,000,001 things at once.
Well, it's like in community, isn't it? The slots, 20-minute slots, half an hour slots, the clinics are so full that often the women are only being seen in 10 minutes. But then what are you actually missing at that point? You should be doing the fundal high, and that's where you're seeing these small babies and then going for the extra scans. If that's been completely missed and you suddenly then have a baby that's not developed correctly, then is going into labour, is already in a position of struggling, and we there's potential to be completely missing that. So as midwives, we are the experts in normal. We're with women, but what's really important is that we're able to establish when something isn't right, and when we need to escalate to our peers for support. Embrace and HSIB, they all say that there's been plenty of missed opportunities because of poor escalation or late escalation. So I think that's really important that we go through that and discuss that, so everyone can understand why that's so important. So we've got recognition. So, are midwives able to recognise the initial something isn't right here? This might be CTGs, it might be maternal observations, or conditions. So is her blood pressure rising? Is her temperature rising? But sometimes it can be so subtle that when you stand back and look at it as an outsider, you could think, well, how have you missed that? But actually, when you sat with someone for 8, 9, 10 hours, it's that real subtle eye that you need to pick up on those. And sometimes, naturally we miss them.
And I think as well, the human factors come into play with it. We are only human, and you can try your best. Shifts are tiring, and a lot of other factors come into play. Like, there's only so many members of staff on the shop floor, as we call it, and all it takes is for you to be called away to perform a fresh eyes, which is a safety measure, in another room, because you need a staff member to leave the room to be able to go to your room to perform it. And you could miss the most subtle change of concern while you're out that room, and then you walk back in and you're like, well, I was only gone a couple of minutes. but labour is just so unpredictable, unfortunately. And I think as well, it depends on, I've said it already, but how confident you are in your own practice, because even the most experienced midwife, you know, we are human. You can just miss something so basic that you just don't think is, you know, anything to really worry about. And you think, oh, no, that's fine. But you go to escalate it to your band 7, and they sometimes, you could get in a situation where they say, oh, no, that's fine. Oh, I think that's adequate progress. Or, oh, no, that's ETG. That's okay. Don't worry about that. And as you're more senior, you have to really weigh it up in your head and think, well, you know, they are midwife in charge. Like, do I agree with what they're telling me? And do I trust that actually I agree with their judgment? And as a midwife, I think you need to be autonomous. You need to then turn to yourself and go, does this decision fit comfortably with me, or do I want to take it further? And a huge part of the whole multidisciplinary team is a good working relationship. All it takes is to have a obstetrician that kind of almost sees your escalations as an annoyance, and you start to overthink yourself and you start to second guess whether your escalations are necessary, and you get met with a bit of pushback, and they go, no, I don't need to come and see your lady. I'm happy with what you've told me verbally. I don't need to cast eyes on her. You're being worried for no reason. But sometimes you just have an inclination and you just need a bit of reassurance from someone else. And it's how they respond to you at the time. You can give them all the information, but I feel sometimes you just have a feeling and you just want a bit of reassurance from someone else.
Yeah, and I think we see this often with very junior midwives. I think it sometimes can be well known that junior midwives are given actually quite high risk cases because they're seen as potentially boring. Like syntocinon, for example, you know, you can be sat in that room for 12 hours. You don't get to really talk to anyone, but actually these women are really high risk. And then you are putting very junior midwives in there. And if you have a trust that hasn't established a really clear protocol for escalation, then actually that's very incredibly difficult to do. You're putting them there. One, you know, have their skills developed enough to pick up on these really subtle escalations? Secondly, do they understand the route in which you need to go? Like, do I speak to my band 7? Is this an SHO or a registrar discussion? Is this actually needing to go straight to the consultant? Which, you know, is, even as a qualified for a bit longer, is incredibly hard to actually ring and discuss straight to the consultant. So I think it's that understanding and the protocol and having everything so black and white for everyone. And I think this is where the SBAR communication comes in really handy. So everyone follows the same pattern and it's very clear on you know, where we're actually going and what do you need and how to ask for that.
I think as well, though, there's no harm in re-escalation. We're just talking about escalation here, but I've done it thousands of times where I've had my review, I've escalated, midwife in charge, then the doctor comes in and goes, I'm happy. They document, so I've got it, you know, written down that everything's okay, and they're like, no, continue. They tell the woman and partner or birth partner, no, everything's okay, like we've just come in because the midwife asked us to, but we are happy. And there's absolutely nothing wrong with re-escalating 20 minutes later. Things can change so quickly. And timing is so important. And that's where it links to your documentation. It is so important in the records that we are aware who attended and when. So many times you'll see a date, but no time. Really difficult when you're putting the records together. You can kind of read the records and you're like, okay, well, I know she was in labour, but I don't know at what stage. But the minute matters in these emergency situations. And I always make sure that I write in my records when I'm practicing, I'll write like, for example, X is now in the room after I've asked for a review, because sometimes your time of escalation to the time of attendance can be severely delayed. And, you know, we'll look at records and be like, why did it take them an hour and a half to attend? Where were they for an hour and a half? I think the way that you write your records as a clinician is so important. I personally would always write, I have contacted them 3 times, unable to discuss because are scrubbed in theatre with X emergency. Doesn't need to have any patient identifiers of whoever they are currently with, but just for some actual awareness of what is going on in the unit, so that when you retrospectively look back at a case, you can kind of piece it all together and figure out why there was such a delay in the first place.
Yeah, and I think that's why SBAR, to go back to that, is actually really important because it's so black and white. And I think this is where trusts should be following that, basically. I think you see in SBAR within the records, and it's very clear on what you're actually saying to the doctor. So you're looking at the situation, you're explaining it. You know, for example, we've got a grab to do para 1, she's been in labour, and the next stage is background. So if she's got any conditions like diabetes, you know, they're all things that are building a picture to this very busy doctor about how quickly do I need to see this lady. You've got the assessment. So, you know, for example, she's on a CTG and you are concerned with your CTG, you would say, I have late decelerations on my CTG and I would like a review, please. So that would be the recommendation aspect of the SBAR. And, you know, when you look at that, if you're repeatedly seeing that within records, then you know that this midwife she's escalating, she's explaining, and it, you know, it's just very clear cut, and it's very clear that she's escalating appropriately.
I think as well, there's always an assumption that everything will be fine. I think we normalise in a high risk unit that we've seen this before. So, actually, in my experience, like this has happened before, and actually it's always been fine. And we look at a CTG and you just have a gut feeling that something is wrong and you just really want that baby delivered because you just think it will be safer. And then someone comes in and goes, I've seen that before and it was absolutely fine. But it doesn't matter. Every baby will cope with labour differently. Every woman is different. There are so many different factors that go into it. You can't compare a labour to the next. They're all so different. And because we look after so many people and what we do is kind of like a conveyor belt system, like lady in labour, see her through labour, delivered, on to the next. I think people forget that they are actually individuals, and I think we get it wrong quite often. We're not very good at just taking them for themselves, making a holistic assessment of them and seeing them as their own. And then we just get a bit complacent, I feel sometimes. And I wouldn't like to brand all the obstetricians the same, but I do feel as midwives, we are quite good at kind of making the woman into their own and their own person and being like, well, no, this is different because, you know, this and that. Whereas you'll tell a doctor, but to the doctor, they've got the entire labour ward under their remit. Whereas we at the point of being in labour with a woman are only focused on that one. So we're able to see little tiny things changing because we're in that room all the time.
And I think that's the issue with that is we're losing that skill though, aren't we? And I think, you know, it's very hard now to be low risk. Everyone is high risk. So the high risk becomes normal. And actually low risk is almost abnormal now. You know, we see lots of closures of the maternity-led units. And I think we are losing that skill. But equally, we're not trained to that extent of doctors either. So we're kind of stuck in this really difficult balance of, yes, we are trained for normal, but we don't see it. It's just not happening anymore like it used to. So when I look back at the cases that I've worked on, I think absence of records is always going to be huge. You know, are there huge gaps relevant to the case? I think the biggest one I often see is the timing between going to theatre and actually going to theatre. You know, it could be 5 minutes, 10 minutes, it could be 40 minutes. What you don't realise on paper is how busy that unit could potentially be. How many other cases have they got in theatre and trying to manage that? But quite often, because, you know, they're trying to organise things like theatre, getting all the scrub nurses, even getting the TED stockings on, you know, it's all stuff that actually takes quite a lot of time. And often you see that your documentation can be quite poor. But, you know, if you have a CTG and it's actually not looking great and it's classifying as abnormal, where the records, what's the midwife doing? Is she continue to escalate? Should we be going to theatre faster? And it sometimes makes you ponder, you know, what's happening at the time.
And those moments are completely critical, obviously, to the entire picture, but a huge part of our role is to identify what is missing. So to the outsider, they wouldn't think like that CTG needs to be continuous right up until the moment the baby is born. Quite often I look at records and you kind of stop at one point and then suddenly the baby's born and you think, well, hang on a minute, there's a 30-minute gap there. And actually, was it ever in existence? Has it now gone missing? Or just did it never happen at all? And actually there was no fetal monitoring whatsoever. And that's where it's really important that we have clinicians who have practiced in that area, understanding that no, there should have been a document up to that point. And as well, we see it with something called cord gases. So midwives can take a sample of blood from the cord when the baby is born, because there's vessels within the cord, and it can give you a really good idea of the environment that baby was in at the moment that it was born. So the blood is in a little syringe, and then we use a special machine that is worth a lot of money, and it will give us a value, and that will tell us the degree to which that baby was struggling in utero. And that can kind of give you a really good idea about whether actually they coped really well, and actually, despite all our concerns and immediate threat to life that we thought we needed to deliver the baby then and there, actually it was not too bad. But actually it can also tell you, no, that baby really was struggling, and that could lead to you getting reviewed by the neonatologist, because you're actually quite worried that the baby was born in a really difficult environment, and actually the levels are quite dangerous. So in brain injuries, usually we would see a set of cord gases. Sometimes though, multiple different factors can come into play and they weren't taken. For example, a very premature infant is going to have a really thin cord. And as if you weren't a midwife, you wouldn't know that. But it's really difficult to get a cord blood sample from a micro premature infant because the cord isn't juicy, and sometimes they're born really quickly. And by the time you then get your equipment, you don't have enough blood in the cord to get a sample. So that's not going to help when it comes to a birth injury. So it's our job to kind of flag it and say, did it ever exist? And then, you know, it might have existed and it might have been lost, or it might have been not declared. But most of the time, any concerns as midwives that we have with a baby, if we have any thought that that baby was struggling, or we've had to do any emergency procedures, we will take a set of cord gases, because that can really influence our decision making.
And I think with the ongoing care, the cord gases are really, really important. They don't just show what the baby was like at birth, but certain levels can show if actually this baby has been in distress for a long period of time, or whether it was an acute episode. So for example, if it's a cord prolapse, often the levels will show it's an acute setting. However, they can also show that actually this baby has been struggling for a long time. And, you know, you can look at the records and think, well, this woman's only been in labour for an hour and the baby's been born. So what's happened in the moments prior to that that's led this baby to have cord gases so poor? And this is where you also need to look at triage visits, for example. You know, sometimes you think to yourself, gosh, how did this baby get so unwell? And often there's triage appointments prior to that. So we need to be looking at, was the woman seen appropriately? Did she have the correct investigations? Are there CTGs for those triage? Sometimes complete triage assessments are just not there at all. And I think as midwives, we are really good at noticing that, whereas other people might not be.
So I think the first thing that lawyers should be kind of thinking about when families approach them is they should be asking the question of, does that family actually have some really strong concerns with their care in the first place? Usually a family would not approach a clinical negligence lawyer if they didn't have concerns in the first place. Something has led them to believe that there's been a fault there and they feel like somebody is negligent. So they should be asking the question of, have they gone down the route of having a debrief so that they can sit with a clinician and go through what happened? Because sometimes the way in which the family portray the events is different to actually what is written on paper. And it's because they're maybe sleep deprived and they aren't truly aware of what was actually happening at the time, that they're so traumatized from the event that they have in their head a way that they thought it went. Actually, all steps were followed and safe care maybe was given. And actually, there may not be any negligence present.
That's it. And then the second question they should be looking at, or the second point, is what is the injury? What's the diagnosis? So we need to be looking at what everything's been classified at, what grade it's been put at. Is it static or progressive? So actually what the child or the infant is suffering from, is that going to stay the same? Is that going to worsen? What's the prognosis for this baby? Is it actually, it might be that education might need more support. Do they need special equipment? You know, it's very, very different. And I think actually you need to be very clear on the diagnosis of that.
And the diagnosis, as we already said, it's not necessarily a short-term management. The long-term impact to the infant may not truly be known until the child starts to grow. So by law, families can claim for an infant up to the age of going up to 21. So there's plenty of time if people feel that they have been affected by clinical negligence to look back into their care and see whether something did go wrong. But if an infant is so small and hasn't even developed yet, the true impact of a birth injury may not be noticeable. And if they're looking for financial compensation because of the care that their child now needs, they didn't expect to have to care for a child that needed that level of care, and now they need more support with that, then it may be that they need to seek more specialist input, get more expert opinions, and see more specialities to actually just take the term brain injury and actually look at what it actually has impacted in their child.
Yeah, then the next step following that is looking at the records. Is there any causation or timing to the injury? So is it very clear cut? The very acute kind of injuries such as quad prolapse or shoulder dystocia, I think often those things are easier to diagnose. They happen very quickly and it's quite clear that is the event that has happened. However, babies that have been in distress for a long period of time, it's really, really difficult to actually even put it to the minute to which that baby was put at risk. So if I could tell one thing to a clinical negligence lawyer that they might miss is to remember that, it's a very emotive subject, birth injuries. It's not just physical things. It's not just money. There's a lot of emotional attachment to all of this. Women and their families, they want answers. They don't necessarily even want any money. They want to know what happened to the child, and they just don't want it to happen to anyone else. They often, when you're pregnant with your children, you often dream about what you want to do. And whilst all those things are always possible, just being able to walk out the door really easily, it's things like that they miss. And the fact that often couples split up, there's higher divorce rates, they might have to move house, it's all stuff that's incredibly wearing mentally and physically. And actually, there are real people behind this. So to summarise what Meg and I have discussed, I think the biggest thing would always be escalation. Positive escalation brings better outcomes.
And then the team you're escalating to matters. So having a really good positive working relationship with the people that you're on with a shared common goal, which is a healthy mum and a healthy baby.